Hello, how are you? Welcome to our 4th International Symposium and 6th Virtual International Symposium of the UNSA Group in Colombia. It's an honor and pleasure to be with you all, as I know we can contribute greatly to enriching your knowledge in many areas of infertility. To our Colombian colleagues who've supported us, and those from the US, Suriname, Dominican Republic, Antilles, Venezuela, and all interested parties from other Latin American countries, we hope this symposium is a success, both for us as a group and especially for your learning. Today I've been tasked with discussing Isthmocele and endometrium management in assisted reproduction. I'd like to begin this topic with the following analogy. Always in medicine, we tend to go from simple to complex, often forgetting to the simple often comes later. After evolving from simple to complex, we return to simplicity. I'll illustrate this journey through endometrial changes in embryo implantation. Discussing simple to complex, let's revisit endometrial dating from my generation. At 60, those of us aged 50, 70 first approached endometrial study via Neuer's dating criteria. We'll then explore molecular evaluation, gene expression, and Isthmocele's impact on implantation. Going back to Neuer's dating criteria, we're talking about the 1950s, when his initial work with 300 patients generated knowledge that lasted for decades. In studying the endometrium during the luteal phase, we performed biopsies on days 21 and 22, followed by a histopathological study to determine if the endometrium is in phase or not. This helps us decide on the best therapy to improve the patient's chances of pregnancy. As we've progressed into this century, we've moved to a more advanced and definitive approach, molecular evaluation of the endometrium. Studies from the 2011 Human Reproduction Update summarize how the endometrium is molecularly affected by various pathologies, including endometriosis, hydrosalpinx, leiomyomas, endometrial polyps, and polycystic ovary syndrome. They propose endometrial mechanisms affected primarily through altered molecular expression of HOXA1, HOXA10, HOXA11, leukemia inhibitory factor, integrins, and other molecules. These pathologies affected the endometrium in each case. In that same paper, they suggest clinical interventions for these patients based on the pathology to improve endometrial implantation. For endometriosis, they recommend excision or diathermy ablation, myomectomy for leiomyomas, and salpingectomy for hydrosalpinx. The hydrosalpinx research has an interesting background. Early studies on how hydrosalpinx and tubal blockage affected embryo implantation were based on the fluid trapped in the hydrosalpinx. They cultured mouse embryos in this fluid and found that embryos in cultures with hydrosalpinx fluid had reduced blastocyst development. This led to the solution for patients with infertility and a history of ectopic or tubal issues who needed in vitro fertilization would have much better results if a salpingectomy was performed prior to the procedure. For endometrial polyps, surgical correction via hysteroscopy is key. For polycystic ovaries, weight loss and oral hypoglycemics are crucial. For endometriosis, GnRH agonists and surgical excision are recommended. For endometritis, antibiotic therapy is vital. This condition deserves special attention as it's common to have subclinical endometritis that's hard to diagnose. Antibiotic therapy, in cases where endometritis is evident, has a positive effect on endometrial implantation. For patients with endometrial dysfunction due to ovarian hyperstimulation, nowadays if more than 10, 15 eggs are retrieved, the trend is to freeze the embryos and do a delayed transfer. This covers the molecular evaluation. Next comes gene expression, the latest development in endometrial and implantation studies. At the start of this century, IUMD Iudis proposed In the genomic era, we could study which genes were expressed at the endometrial level during implantation. This gave us a map of which genes were overexpressed or downregulated in the endometrium during the implantation window. Following Linda Giudice's studies, the IBI group, led by Carlos Simon, Dr. Peguesa, and Jorge Callejas, presented a new way to study the endometrium by evaluating gene expression in these tissues during the implantation window. Their initial research focused on how genes were affected, which were down or upregulated during ovarian stimulation with agonists or antagonists. This led to a pioneering study in this field, which was the endometrial receptivity study, later evolving into metabolomics and microbiota research of the endometrium. All this, like any medical technique, initially experienced overvaluation and overuse. Over time, it underwent what Garner postulated. All new technology in any field of human knowledge initially rises, gets overhyped and overused, then time and evidence often lead to disillusionment, abandoning these techniques, or time establishes an appropriate productivity plateau. That's where we are now with endometrial receptivity. There's still clear evidence that all IVF patients should undergo endometrial receptivity studies. Why all this? To show we go from simple to complex and back to simple. This is where Isthmocele comes in. First, let's note that cesarean rates worldwide have been increasing. This global rate wasn't available until 2011, when worldwide C-section rates were 30 to 35%. By 2018, we have more extensive global figures by region, showing that the global C-section rate is 28 to 30%. Look at our region, Asia and Central Europe, where C-section rates reach 40 to 45%. If we look more specifically at countries, this table shows C-section rates and the percentage of births in public institutions. In the column where 95% or more births are in public facilities, countries like Dominican Republic have C-section rates up to 60%, Brazil 58%, Colombia 52 to 55%, and Ecuador is around 50%. In conclusion, 50 to 60% of first-time births are C-sections, rising to 80 to 90% for IVF patients. So what's the deal with these C-sections? C-section as a cause of infertility, considering Isthmocele, the defect in the C-section scar as a surgical complication, can impact the correction of this isthmocele and affect assisted reproduction therapies via hysteroscopy or laparoscopy. To provide context about the definition of isthmocele, it's a defect or recess in the cervical and isthmic region that acts as a sac or reservoir. Morris first described it in 1995, studying uteruses of women with C-section history, and today Isthmocele prevalence is reported up to 52%, visible on ultrasound as a defect, an area of discontinuity in the isthmic zone of varying degrees. We'll discuss grading soon, but it's easily detectable on an ultrasound. What risk factors increase the likelihood of isthmocele after a cesarean section? Key factors include obesity, retroverted uterus, multiple prior C-sections, and emergency C-sections after prolonged labor. Complications during the cesarean are another risk factor, such as when a patient experiences tearing. The surgical technique used during the C-section, including the debate over double layer versus single layer closure, is also important. Reabsorption, or a very ischemic structure, increases the risk of hydrocele as a scarring complication. Labor duration before C-section over 5 hours and cervical dilation above 5 centimeters before the C-section, as we mentioned earlier, or prolonged pushing phases. These are risk factors that make it more likely for a patient to develop a subsequent hydrocele. How do we diagnose it? I mentioned it before, but let's explore it a bit more. Ultrasound is the most common initial diagnostic tool. It appears as a triangular anechoic area with the apex at the front wall. I'll show you some 3D images now that make it much clearer. The defect can also appear as a mass between the bladder and lower uterine segment containing debris. Another proposed ultrasound diagnostic criterion is fluid in the uterine cavity, which can be identified in up to 42% of patients who have hydrocele. During hysteroscopy, as we enter the uterus, we get a direct view of this pocket. It appears as a wedge-shaped pocket at the cervical level, often containing inflammatory fluid or blood, surrounded by a fibrous ring. The following images show hydroceles of varying degrees. Here we see a remnant wall over 5 mm, but a clear defect is visible. This image is interesting as it shows an anechoic line indicating fluid in the endometrial cavity. Here's the hydrocele, the triangular defect, and fluid in the endometrial cavity. Hysterosonography helps classify it. There are many classification systems. In one system, severe hydrocele is when the anterior remnant wall is below 5 millimeters, and if it's under 5 or 3 millimeters, these patients will have better outcomes with isthmoplasty, or the procedure will be easier to perform laparoscopically. Other patients can be treated with hysteroscopic resection of the isthmocele, which we'll see in some images later. This is another view using hysterosonography. Here's the cervical canal, and here's the defect where we can measure the remaining wall and classify the isthmocele. In 3D images, we see the discontinuity at the cervico-isthmic level in frontal and lateral views, showing the defect area. What complications can arise from an isthmocele? There are both obstetric and gynecological complications. Obstetric issues may include placenta accreta due to abnormal placentation and suture dehiscence, which could potentially lead to a uterine rupture, and ectopic pregnancies can occur in the caesarean scar area after a C-section. Gynecologically, there are several issues. Importantly, women post-C-section may experience abnormal uterine bleeding, dysmenorrhea, pelvic pain, and post-coital bleeding. Infertility is another concern which we'll discuss in more detail shortly. Endometriosis, adenomyosis, abscess formation, and higher risk of complications during gynecological procedures can also occur. What's the proposed mechanism for how this caesarean scar defect, reservoir, and inflammatory area causes infertility? Persistent menstrual blood in the defect can negatively impact cervical mucus quality, altering sperm migration and capacitation. It can affect embryo implantation due to a chronic localized inflammatory state that starts at the defect site and spreads throughout the endometrial area. Many studies show reduced fertility after C-sections, much lower than natural births. Pregnancy rates may drop by 10% in women who had C-sections compared to those with spontaneous deliveries. In conclusion, Isthmocele can be a significant cause of infertility. The hypothesis: mucus buildup seen on the right when entering the hysteroscope, which appears as an area with mucosidin deposits, the sac fundus with inflammatory zones. The solution will be to tunnel that defect and, most importantly, ablate the area and the inflammatory sac fundus to prevent that area from producing exudate that will affect sperm migration and impact endometrial implantation due to the toxic effect of this inflammatory state on the embryo and gametes. To conclude, we have a significant series of 58 cases. many of whom had previous IVF, C-sections, and underwent frozen embryo transfer. Many had secondary infertility with unexplained prior C-section, simply found as Isthmocele. From this series of 58 patients, we observed after hemoplasty a live birth rate of 45% in patients under 35 years old and a rate of 50% in patients over 35 years of age.
35 years old.
In total, 62% of IVF patients diagnosed with Isthmocele and treated via hysteroscopy had a positive pregnancy test post-surgery. What I brought today is to remind you about the endometrium at the endometrial level, how we study it from basics like endometrial biopsy to molecular and genomic studies. Remember, there are simple factors like prior C-sections that can affect future fertility. We must be aware of this condition. As takeaway points, Isthmocele is increasingly common, with C-section rates in our countries at 50 to 60%. It's a sole or associated cause of secondary infertility. Isthmoplasty is shown to restore natural fertility and yield good results in assisted reproduction patients. It's advisable define presence of Isthmocele in all pre-cesarean patients with secondary infertility and correct it before starting assisted reproduction therapy. I hope you found this topic interesting and that it provided new insights. It's crucial to remember that for pre-cesarean patients with secondary infertility, we must identify Isthmocele. On behalf of my team, I greatly appreciate your attention to this presentation today. Thank you very much.